Women should remember that it makes a difference when you are at the table because your ideas do matter. I think there needs to be a change in the mindset, and a change in the mindset will save lives.
A lot of times the change has to happen from top down.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. I'm excited to introduce today's topic: women in cardiology, underrepresented but essential. Heart disease is the #1 killer of women in the United States. Yet recent research published by the Journal of American College of Cardiology reports that despite current targeted national efforts by the professional cardiovascular community, cardiology and interventional cardiology still persistently rank at the bottom in terms of female representation. Only 13% of general cardiologists and only 4.5% of practicing interventional cardiologists are women. MedAxiom and its parent company, the American College of Cardiology, encourage women cardiologists to network, share their ideas, develop leadership skills, and advance their careers. In today's episode, we will explore why this call to action is essential for cardiovascular programs and for patients. Our two guests are both ACC fellows practicing right here in Jacksonville, Florida. Dr. Pamela Rama, a non-invasive preventive cardiologist who says she has a special love for working with female patients and their specific heart needs. She is Chief of Staff and Medical Director of Cardiopulmonary Rehabilitation for Baptist Health. We also have Dr. Ruby Satpathy, an interventional cardiologist and the director of the Structural Heart Program at Baptist Medical Center, Jacksonville. Welcome to the podcast, Dr. Rama and Dr. Satpathy.
Thank you for having us here today, Melanie.
Thank you, Melanie.
All righty, so let's get started. The first question we ask all Heart Talk guests: what was your aha moment when you decided to get into healthcare? Share a specific moment if you can remember one. Dr. Rama, let's start with you.
My moment is really a funny moment, and my daughters have asked me never to repeat the story, but I'm going to have to do it now. So when I was born and raised in the Philippines. It's a third world country. People were poor. There was really no healthcare insurance. And if you needed healthcare, people would sometimes pay you in kind. And so my best friend's parents were both doctors. And I remember visiting their house one day. I went in there and I saw a big bushel of crabs, and I love crabs. And so I asked her, well, where did the crabs come from? I've never seen so many crabs. And she said, well, one of my mother's patients gave it to her. And I said, oh my God, I'm going to be a doctor. So for me, the reason was, I was young. I figured if I were a doctor, I'll never starve. And so, that was my first thought. Obviously now I love my profession and because it helps so many people, but that was my first aha moment.
I love crabs too. Have you ever been paid in crabs?
Not in the United States.
Right. I wouldn't complain if that was in a paycheck one month. Dr. Satpathy, same question for you.
So it's interesting because when I was, I grew up in India. I don't remember how I became a doctor, but I would tell you how I became interested in cardiology. I was in medical school, so I was 17, and we had not too many girls in my class, and I know we're going to talk a little bit about that later. And my sister is a cardiologist. She still practices. She's about 8 years older to me, and she is a very renowned cardiologist in India. And this time she was practicing, and I remember in my light days, I will follow her in the hospital. It was the middle of the night. It was a STEMI. And this young gentleman was having a heart attack, and she explains to me what she's doing. And she was able to essentially, give him a second life. And that I remember, and I was so intrigued sitting in the control room. I'm like, this is exactly what I'm going to do when I grow up. So that was my aha moment for practicing cardiology. I knew before even I went to medicine that I wanted to do cardiology.
Pretty awesome that you had that role model at such a young age. Dr. Satpathy, you're in an elite group. How does it feel to know that you're one of 4.5% of practicing interventional cardiologists who are women?
It's very interesting. In fact, I was on a national call just night before last night, and it was the same question. And I know you don't have it here, but there's another interesting number that is even worse than that, or better than that, however you want to say. So we have 13% cardiologists who are females. You go to interventional cardiology, it's 4.5%, and I do structural heart intervention, and there are only a handful of female structural interventional in the whole world, not just US. And it's probably maybe 10, 12 at the most in the world, maybe 5 or 6 of them in US. And so I don't even want to say the percent. It's certainly less than 1%, maybe 0.8. I think there may be 200, 250 structural interventionalists in the whole world. So the percentage even goes down. I would tell you a couple things, and I think it's very important for next generation to hear. When I was a fellow, I always wanted to do intervention, and I remember going to these meetings as an audience, and I was probably the only female. This is 15 years ago. I think the change I'm glad it is happening. There is more to do. I think the reason for that is, ladies did OB for a long time. They had to come in the middle of the night to do delivery. So it's not necessarily that they were scared of cardiology, but I think it has been historically so male-dominated field, and there were not many role models like Pam, like me, that people just, they just didn't think they could survive. But now we know they could survive, not only survive, they could thrive. And I think, our generations like me and Pam, and when I'm sitting in the structural meetings, I think we are role models, and we are probably more warm, maybe welcoming. I'm very welcome. People write email all the time. They come to me after talk, and I think we have been able to show the next generation that it's not about gender. If they are good, they are skilled, they are knowledgeable, they could handle a STEMI in the middle of the night. They could put a valve in somebody's chest, and they could be a great cardiologist and do whatever they want to do. And having those role models, that I think that has helped. And we have more work to do. I think there is still more to do to change these percentages, but wow. It's happening, and I'm very happy to share that.
I think you make a good point that representation is so important, and not just being at the table. You have to recruit others at the table as well. Let's talk a little further about some of the challenges you faced along that journey to become an interventional cardiologist.
So yes, there has been challenges, and the challenges were not, again, I think it's a mindset more than anybody in particular, in personally, trying to hurt you. But I think it was the mindset. I still remember when I wanted to do structural interventional back when I was a fellow, the head of the CT surgery program, Jeff, who later became a colleague, but those days I used to say Dr. Sujimoto, he told me, Ruby, this is not going to take off. Are you sure this is what you want to do? Are you sure you don't want to do something else? But I think that was the mindset 15 years ago. I think it's changing because of two things. One, I think we have been able to show that females cardiologists are equally good, and maybe sometimes we have more compassion factor. Again, nothing against male, probably that comes in. Again, I always say as a doctor, it's a profession, it's the knowledge and it's treating, but there is that compassion factor that separates our field from other fields. I always say, knowing what I would do if the gentleman who is sitting in front of me was my dad or my grandmother. I think that compassion factor is important, and I think if we combine the knowledge with the compassion, we can be great physician, cardiologists, interventionalists. I would say that people are more accepting, and I see a lot of, I'm on the panel a lot, and I see our male colleagues have a lot of respect now, and we get called upon a lot of times for opinions on any questions in cardiology field, or sometimes when they're in the middle of something in a difficult case, to get opinion or help them, just like they would call a male colleague. So I think it is changing, but it wasn't the same 10 years ago.
Mm-hmm. Yeah. So it sounds like, that confidence is key, but also recognizing that the compassion that you bring to the table is just as important as the knowledge and that history of having other women to look at. What advice would you give women who are thinking, this would be something that I'd be interested in, but maybe a little intimidated?
I would say, do not get intimidated. Just be yourself. You can do it.
And come to you, because you're a wonderful example of what
Absolutely.
can happen.
Absolutely. Anytime. Happy to help. This is one of my passions, to be able to generate the interest and make it a more diverse field. We have a lot more work to do. Percentages are right in front of you. 13% in cardiology, 4.5% in intervention, 0.8% or so in structural. We have more work to do. I think it also helps the patients if we have a diverse on the physician side. I think it makes more female patients to be comfortable that we're thinking about them, to include more female patients in our research patients for future cutting edge technology. If they know that there is a PI, principal investigator, is a female, it helps. It helps with anything, gender or racial diversity.
It does, and as we just finished Go Red Day not that long ago, awareness for heart disease in women, it's a spotlight now. So women do make that connection with other women, and it's good to be able to have you all in that role. I want to bring Dr. Rama into the conversation, because I remember many years ago when we first met at Baptist Health, there was a news conference and all these beautiful, smart women were brought out, and this was the cardiology team. And I remember thinking as a newscaster, this is a story. 6 female cardiologists at Baptist, which is really impressive. It seems like this should be the standard, but it's not. So in what ways does having 6 women on your team benefit your internal physician culture and also your care team?
Oh, it is incredible. I think that when I leave my practice and finally retire, one of my legacies, or one of the things that I want to be remembered for, is I was part of the group that brought 5 amazing, intelligent, compassionate female cardiologists to Jacksonville. Really, it changes, because I've been with this practice for 20 years, and I was the first female cardiologist. And, every time we added a new female cardiologist, you could just see the change in the culture, and it really made me happy. I'm lucky to be in a group where, my partners really respect us. And there was nothing about women are lazy, they don't work as much because they have to take care of the family. I didn't feel any of that. And when I joined them, I had 2 little kids, and one of them had febrile seizures. And I remember one day I had to get off work because my son had a febrile seizure. And my partner's response is like, go take care of your son, we've got your back. And I think that was very important for me to hear. And when I saw that this was a practice that accommodated women so well, I felt that we needed more women in our practice. And you know what? I think the women in our group are very popular. There's a way to get into to see them. And it's just different. We are more compassionate, we're more empathic. And I think patients are able to relate better to females because we listen better.
Yeah. And again, we want to point out, nothing against men. I got a husband and an 8-year-old little son around here who we love dearly. But I do think, to your point, that compassion and that connection is important, especially to your female patients. Can you think of an example or a time when you knew that you were making a difference as a woman physician?
I have a very good relationship with my patients. They talk to me about their lives. So I have patients who I've known for 20 years. I've known it when, they got married, when they got divorced, when, they ended up with children and got married again. And so I have a special relationship with patients. And I think that, there are a lot of instances wherein somebody would recommend this testing. One of my partners would, and not to say anything bad about my partners, but they would always turn to me and say, "What do you think? Do you think that this is the right way to go about it?" And it makes me feel good that they trust me, and I think it's just we we're able to communicate better, and they understand. As a woman, I think I understand, and I have been a patient as well. So as a woman, and I've been a patient as well, I know how to approach women to make them more comfortable and reassure them that what we're doing is the right thing.
Mm-hmm. That mutual respect is so important.
A couple of comments that I would add to piggyback on what Dr. Rama said. It'll be incomplete if I don't say that. One is, I think it is very important to have the buy-in of our male colleagues as well, to grow the interest and grow the percentage of females doing cardiology. And I would tell you that's the other thing that had changed in 15 years. And I completely agree with what Pam just said. At Baptist, my partners, our administration is very, very respectful and for the knowledge that all the 6 female cardiologists bring to the table, to the point that I would want to point out that a lot of us are in a strong leadership roles, and they do it very well, and they're well respected. And all of us are involved in many different roles, and adding not just to patient care, but adding to the growth of the service line, the service to the community, the vision for next 10 years. So that's one thing that I do want to say that's important. And number 2, I do want to say, I think it's just not female patients, but I have felt that with male patients as well. I think it's different when you bring the compassion factor. I mean, there is a study from Harvard that shows that the female surgeons had better outcome than male surgeons. Again, nothing against it, probably are equally skilled operator, but just maybe having that compassion factor and, taking that extra whatever, the compassion and the care probably, was the main reason for the outcome difference. And so I think I have seen both male and female patients actually trusting what Dr. Rama said, saying, "What would you do? We really, will trust whatever decision you make for us, knowing that we'll make the right decision."
Right. We're all in this together, and it is elevating cardiology and the practice for all of the patients. We'll be right back after the break. MedAxiom members, are you wondering how you can do your part to help transform care? Submit your data for our annual MedAccess Survey, and together we can reshape the way we do care. If you submit your data before the March 1st deadline, you'll receive free access for one employee to take the Cardiovascular Coding Essential Education Series. Go to MedAxiom.com/annual survey. That's MedAxiom.com/annual survey. Innovation starts with you. Welcome back. Before the break, we talked about how having women cardiologists benefits physicians and providers and patients. So let's talk a little bit more about that patient perspective. Harvard University's Dr. Cody Stanford says, it is important to have a healthcare workforce which represents the tapestry of our communities as it relates to race, ethnicity, gender, sexual orientation, immigration status, physical disability status, and socioeconomic levels to render the best possible care to our diverse patient populations. Dr. Paul Rotham, Dean of Medical Staff at Johns Hopkins, says when the physician is the same race as the patient, patients report higher level of trust and satisfaction. The visits even last longer by 2.2 minutes on average. When patients enter our hospital, they want to see staff members and physicians who resemble them. And we talked a little bit about that with both of you all. Dr. Satpathy, do you agree that workforce diversity, equity, and inclusion are advantageous for patients?
Absolutely, 200%. I think what you kind of summarized in those quotes very well. I do see, we know this. I mean, there is a lot of under treatment factor, which is because of late diagnosis or in a variation in people having insurance and seeking health care in getting diagnosis in the right timing or under treatment. It's a whole spectrum, but it is there, and it is there more in the minorities, including female, gender, racial populations, ethnicity, and economical diversity. And I think it is very important, if we want to reach out to those populations, treat them better and sooner with the right care, we have to have a diversity in our provider side. And that includes actually physicians, nurse practitioner, nurses, and everybody.
So as a journalist, I'm in the business of storytelling, and statistics say one thing, but there's nothing like that anecdotal story. I think of my mom, who she was having some issues and her blood pressure was going up, her heart was racing, and they were like, oh, it's just stress. And we went to the doctor several times. Oh, probably just stress, till eventually a persistent female doctor diagnosed her and she needed to get a stent. So I'm thinking that this is probably a little more frequent than we like to believe that happens, is that we have to have this advocacy from patients. And sometimes, again, it's that connection with a doctor who looks like you that makes that proper diagnosis.
Absolutely. I think the other thing that, again, we can't change overnight, but if you remember all the research studies that had led to the textbook that students read now, were all done on mostly Caucasian male volunteers, because that's how it worked at that time. Ladies were at home taking care of kids and cooking, and the lack of trust, because most of the research providers were male and Caucasian, so people just really didn't trust it, be that female or be that the minority racial ethnicity population. I think a chest pain, a heart attack on a male that is described on the TV advertisement is very different in females. They may never have that, the crossing chest pain. It might be very different. It might be a stomach pain. And that is exactly we're seeing, that we have late delay in diagnosis, delay in seeking care. By the time we're taking care of them, already some complications have started. The dose difference in the pharmacy and medicine is different between female and male, which if you don't adjust, they get more complications and bleeding. How we do procedures, we are seeing more and more in the surgical side. For example, you said stent, going through a hand, radial, has much less bleeding than going through the groin and femoral, especially in females. Doing a TAVR, a valve replacement, how we do it with a catheter versus open heart is shown more advantageous in females because their structure is different. And the same for racial diversity, but that won't change until now. It's changing. What most of our research studies now, we mandate that we have 50% females, so to make sure we include them proactively to get the data so we can treat the future generations better. And that will happen only when we have more and more female providers on this side so people can trust.
Right. Providers. And as you mentioned, recruitment of people who will contribute to research, women and minorities as well. February is Heart Month, and there's been an emphasis also on women and heart. And I think women now understand that their heart could be an issue, and they're speaking up and they're a little louder. So Dr. Rama, is there anything else specific that you really want to challenge fellow cardiovascular healthcare leaders to be thinking about this month?
When you think about the statistics for females, one female will die of either a heart attack or a stroke every 3 minutes. So the statistics are still pretty bad when it comes to females. And I think one of the reasons why is women don't personalize it. They don't think that heart attacks and strokes can happen to them. And so they delay treatment. They don't seek attention right away. They always blame it on indigestion. I think what we need to do is let the women realize what their symptoms of heart attack is, and that it could be different from males. So they don't necessarily have to have the crushing chest pains. Shortness of breath, lightheadedness, or palpitations can be symptoms of an impending heart attack. They also need to realize that coronary artery disease is preventable. And so you reduce your lifetime risk of developing cardiovascular disease by 80% just with a healthy lifestyle change. And one message that I have for my colleagues is that when a female comes to you with chest pains, palpitations, and shortness of breath, please don't make anxiety your first diagnosis. I think there needs to be a change in the mindset, and a change in the mindset will save lives.
I love that. Dr. Satpathy, have you seen a change in that direction, that, doctors are listening more to women and maybe pointing them down a different direction than just saying, oh, it's indigestion or it's stress?
I think absolutely it's changing, but we're not there yet. I still see delay in diagnosis. So my message this month would be, yes, we're thinking about it more as providers. So my message to my colleagues across the country are, one, what Dr. Rama just said is, do not make anxiety as the top diagnosis. Number two, I think we're learning more. There is more and more data about how things are different, how heart attack is different, how their treatment is different, what medicine we give them is going to be different. So go with the open mindset, and when we're treating females, just make sure that we're doing the right thing for them. If they need some studies, tests, do it right away. If they need a medicine, make sure we're prescribing the right dose, adjust for their body weight. And doing a surgery, make sure we follow the data. There is some already out there. What is the right surgery for a female would be very different from for the same age male. So I think we can change it. I have seen the change, but we can change further. And by doing that, I think we can save more females that are not getting proper care and reduce the statistics in the right direction, make it better.
I love that. So I do want to point out that Baptist is doing something right. With 6 female cardiologists, they are definitely leading the way in that area. So let's look at organizations and how they can contribute to recruiting more female cardiologists and also putting them in leadership roles. Dr. Rama, let's start with you.
Yes. So at Baptist, there are at least 1,500 medical staff, and half of that are women. So around 50 to 60% of the medical staff at Baptist Health are females. Yet when you look at the statistics as to how many of them are in leadership positions, it's really very little. So I am surprised. And I asked myself, why is that? And so around 5 years ago, we formed a group within Baptist, and it's called Women in Medicine. And its sole purpose is to get women together, discuss what the problem is and why they are not in leadership position, and push them towards, or empower them towards, going after leadership roles. And I think one of the differences that I learned between men and women is that women usually wait to be asked to see if they want to be in a leadership role or not, whereas men always volunteer. And that's the reason, I was the first chief of staff around 10 years ago. Before me was Dr. Carson 20 years from then. And now, because we've empowered women with this group, we're seeing more and more people wanting to be in leadership roles. So we've had a recent chief of staff over at Baptist South. The chief of medicine at Baptist South is a female. The chief of medicine over at Baptist Downtown is also a female. And of course, Dr. Satpathy heads the Baptist Heart Specialist. And so I'm really so pleased to see so many women in leadership roles. And I think women should remember that it makes a difference when you are at the table, because your ideas do matter.
Yeah, and be that voice for yourself. Dr. Satpathy, let's bring you into the conversation about what organizations can do to really recruit more cardiologists who are female. And then also, as Dr. Rama pointed out, those leadership roles are just as important, if not more important.
I think they're very important. I think we're talking about two different things. One is every institution, Baptist and non-Baptist, I think it's important to make that diversity, bring in more female cardiologists because they can improve the care in the right direction to everybody. We already talked a lot about how we can do it, but you can only do it by having more female cardiologists. Number two is very important because a lot of times the change has to happen from top down. And a lot of times the institution historically 10 years ago, you would see that, yes, there are a lot of physicians. We already talked how they're 13%, but if there are a lot of statistics out there in the leadership role, it's a single digit number, 1%, 2%. And we have seen that. I personally have seen that in my prior job. And as Dr. Rama mentioned, there was similar trend here at Baptist. We have seen the change at Baptist and at the national level, but there is again more to be done. And it does two things, because it's important for females to be at the table, to have their voice and ideas be heard, and they are part of the decision-making process before the decision is made. So we make sure that we're making the right decision, not just after the decision is made to implement it. And number two is it adds that compassion and the looking at the different perspective to the decision-making process. So I see a lot of trust and respect from not just physician colleagues, from our administrative colleagues at Baptist as well, but there's more work to be done there. And I think that can happen only when females need to volunteer as well. Do not wait to be asked. If you're interested, go for it. Like I said earlier, when I tell my fellows, you can do it. You are very good at it. Just have the confidence and go and ask for it if you're really passionate about it. And to my male colleagues, physician or administration, I would say that just have the trust. They can do it. Involve them more. We will make the future better by having, both male and female leaders at the table making decisions together.
Yeah, there's no harm in asking, because the only thing you can hear is no or yes, which is the better answer.
And most of the time, the answer will be yes. So to my male colleagues, please ask.
Mm-hmm. Dr. Rama, let me just ask one question, and maybe Dr. Satpathy as well. If someone listening is interested maybe in starting a women in medicine group, like what you all have at Baptist, how would they start that?
Yeah, so it started, you have to have an administration that supports it. So that was very important for us. And we basically, because of that, we were fortunate then. We had Audrey Moran, who was who was an executive for Baptist Health at that time. And she was very passionate about this cause. So we got together and basically called to action, called all of the women physicians, asked them to join our first meeting, and we had several meetings since then, and I think that was very effective. So it is very important to have the support of the administration to pull this through.
And I would add that at the national level, we have, it's called WIN, Women in Innovations, is the full form for the abbreviation WIN, and we have met in last 10 years. A WIN committee is there, which holds national meeting for every society. There is one for American College of Cardiology. There's one for, there is a regional chapter as well. There's one for Society of Interventional Cardiology. So I would encourage all practitioners out there, cardiologists, interventionalists, and not even cardiology, internal medicine, all women physicians, that if you're interested, please reach out to your local person and leader and reach out to me or Pam, and we'll be happy to help you in this part of the country.
You all definitely provided a perspective that we don't always get to hear. Love to see those statistics go higher. And I know you all are on the front lines of trying to make that happen. So thank you so much. Next time on MedAxiom HeartTalk, patient access is still a significant challenge, and the pandemic made things even worse. We are talking with one patient who underwent heart surgery during the peak of COVID-19. Not only did the pandemic hinder his access to care, but the onus of his care coordination fell primarily to him and his family. Also joining us is a CV leader sharing innovative solutions to the patient access problem and strategies for putting the patient at the center of care. That's it for this episode. If you liked it, please tell your colleagues and let them know that they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you'd like to send us a note directly or suggest topics, email us at hearttalk@medaxiom.com.